Next up, we have Dr. Shapiro, who is a cardiologist and an interventional cardiologist. You may be wondering, what is a cardiologist and interventional cardiologist doing at a trauma symposium? If you ask Dr. Gross, he is in charge of the ANSEF pump. But also, like Dr. Vissers mentioned today, our patients, it's really about the whole patient and total body. And patients, trauma patients come in with hearts, and sometimes they need Dr. Shapiro. So let me tell you a little bit about Dr. Shapiro. He is practicing at Boulder Community Health at the Foothills Hospital, as well as in Erie and in Longmont. He's board certified in cardiovascular disease and interventional cardiology. After medical school, he attended the Medical University of South Carolina and then completed his residency at University of Virginia. He did his fellowship and interventional fellowship at Washington University in St. Louis. I Google stalked you also last night, and he does like fly fishing. Perfect. Welcome, Dr. Shapiro, please.
Excellent. All right, thank you. It's really a pleasure to be here today speaking with you, and hopefully I can bring some interesting cardiology perspective to trauma. So just to start with, I wanted to think about the idea of whether cardiac pathology is a chicken or an egg. And so I want to go over this just a little bit. And the debate, I think, is still ongoing despite the cartoon. Let's see if I can get this to play. So this is Hank Gathers, and this is a classic video that where really we changed the idea of syncope in sports. But the issue is that cardiac syncope, which is a profound loss of consciousness, can be the cause of trauma in some patients. So I think when we're first evaluating patients, obviously, you have all your trauma algorithms, but one of the things as a cardiologist we want to think about is whether the root cause was something specifically cardiac, because that could be life-threatening for the patient as we're resuscitating the patient, or during their hospital course, or in their future life. So the things that we really consider are things like the ventricular dysrhythmia, so ventricular tachycardia, so a more organized, fast heart rhythm from the ventricle, as demonstrated in the top ECG. Ventricular fibrillation, which is a disorganized heart rhythm from the bottom chambers of the heart. And so those can be not infrequent causes of cardiac syncope. Obviously, there are other non-cardiac reasons for syncope, so we have to kind of discriminate that. Some potential risk factors, so if we know about specific patients, if they have cardiomyopathy. So the video I showed you just before, Hank Gathers had hypertrophic cardiomyopathy, which was a known diagnosis. He was being treated. Maybe he wasn't taking his medications as prescribed, and then had that profound syncope on national TV. Other cardiomyopathies, both non-ischemic, dilated cardiomyopathy. So patients with heart failure are definitely at an increased risk of both ventricular arrhythmias or just syncope related to heart failure. In younger patients, the inherited arrhythmia syndrome, so things like Brugada or long QT syndrome, and then also patients who are having a heart attack would be at potential risk for cardiac syncope. So clearly something to consider if a patient has a sudden unexplained loss of consciousness as a potential cause for the trauma, if we're able to figure that out by people who saw the actual event, that may be something to consider and try to do some further diagnostic testing, for the long-term safety of the patient. Let's see. So to talk specifically about acute myocardial infarction, sometimes it's not as easy as the snake to tell. So I wanted to present a case. So very clearly, when we talk about acute myocardial infarction, obviously there's a spectrum of disease, but sometimes we see, more profound ST elevation, myocardial infarction. We want to diagnose that as early as possible because our treatment is generally rapid revascularization through the cardiac catheterization lab if it's safe. And so this patient presented not with trauma, but with chest pain. But I wanted to just give you kind of an idea of what we do in the interventional lab. So when we took pictures of the right coronary artery, we see that this should come around and look like a C in this picture. And we see this area of staining in the mid portion of the right coronary artery, and there's no more flow. So this is, a cholesterol plaque that has ruptured open and formed blood clot there, and then this patient is having the large inferior myocardial infarction that we saw based on the ECG. So what we do in the interventional lab is that we put a wire across the blockage, and then we balloon open the area. So we see that cholesterol deposit in the mid portion where there was previously no flow, and we see there's a little bit of thrombus still in there. And then we implant a stent. So a stent is a wire mesh device mounted on a balloon. And so on the left, the stent is mounted on the balloon. Then we inflate the balloon. The stent gets crushed into the wall, and then crushes the residual clot as well as cholesterol into the wall to stabilize the plaque. And so here's our final results. And now we see we have a huge vessel. That's widely paid, and there's some distal disease, but that's a small vessel. So the importance is that, if we were to leave that closed, then that large territory of the myocardium would not be having good blood flow, and so the patient could have significant residual disease, could have heart failure because of that, could also be at risk for heart rhythm issues. And so specifically with regards to trauma, what I wanted to talk to you about was the rates of bleeding as well as thrombosis. So procedurally for those procedures, we generally use anticoagulation to reasonably high levels with heparin or bivalirudin. Sometimes we use 2B3As, which are IV antiplatelet medications. And so all of these medications significantly increase risk of bleeding. And then when we place stents, we use dual antiplatelet therapy as standard of care to prevent blood clots from forming in a new stent. And so aspirin in combination with one of the other medications such as clopidogrel, prasugrel, or ticagrelor. So the issue specifically is that, obviously if patients have had significant trauma and then we're giving them lots of medications which increase the risk of bleeding, then, if there's a nidus for bleeding because of the trauma, then they can have, life-threatening bleeding as a result of our procedures. And also patients who are on our medication, so aspirin and clopidogrel, and then have trauma, they would have higher rates of bleeding as well. So we want to keep a close eye out for that. But the challenge is this balance because, if we were to leave these patients alone and they continued to infarct, they could have lifelong detriment to their cardiac function. So just key points from kind of the idea of cardiac disease as a cause of trauma. I'd like people to think, consider whether there may have been a cardiac condition as the reason for unexplained trauma. And then as the patient progresses through the healthcare system, monitor for decompensation suggestive of acute cardiac pathology and decompensation. But I think a key point, obviously, is that we should assume hemorrhagic shock in our shock trauma patients with hypotension, and then keep the cardiac reasons on the back burner if they're not responding to treatment for hemorrhagic shock. So moving on with regards to cardiac injury due to trauma. So obviously, depending on where someone is traumatically injured, there can be acute cardiac or vascular injury. This can vary from benign findings on ECG or on blood testing to acutely life-threatening. And some injuries may be obvious. So if someone comes with a knife wound to the chest wall in the area where the heart is, obviously that might suggest that there is a penetrating trauma to the heart. But with specifically with blunt trauma, things may be more difficult to diagnose. So I think this is, it might project okay. So this is a nice table kind of highlighting some of the conditions that blunt cardiac injury can encompass. So, with rapid deceleration injuries, cardiac contusion, so bruising of the heart muscle is a not uncommon finding. There can be acute valvular injuries. So we'll go through all of these in more detail in a minute. Coronary artery dissection, so tearing of the heart artery, aortic dissection, tearing of the major blood vessel, rupture of the walls or the septum of the heart, blood into the pericardial space or hemopericardium, and then also pericardial rupture. And then finally, arrhythmias, which again vary in severity between the more severe ones like ventricular tachycardia, ventricular fibrillation, to benign findings like PVCs. So I'm sure this video is a little bit more contemporary, so I'm sure people recognize this more recent syncope. So just kind of focusing on the idea that this was caused by the trauma as opposed to causing the trauma. So commotio cordis is a condition where the heart is struck at a specific vulnerable part in the heart cycle. So effectively, this is like an R on T phenomenon, but being caused by trauma as opposed to a PVC. So most commonly, this occurs in pediatric patients because their chest wall is thinner, and generally speaking, it's a hard, small circular object like a baseball, hockey puck that hits the heart at a specific time, and then they go into ventricular fibrillation as a result. So just kind of most of the things that I've already commented on. The other key points, though, that some patients can have this with impact into the steering wheel, especially if they're unrestrained, although airbags may help lessen the likelihood of this. And then in people who are wearing body armor or Kevlar, gunshot wounds to Kevlar vest could cause this as well, or people who have been shot by less lethal crowd control measures. And the key thing is identifying this immediately with an ECG and then defibrillating patients. So we see in pediatric sports that having AEDs in schools, even for young kids, because that really is a life-saving measure and can save patients from any further detriment in their life. More frequently, we talk about blunt cardiac injury related to motor vehicle collisions, as motor vehicle collisions are obviously very common in the U.S., and so that would be kind of the most common cause of this type of injury. Less common, but in Boulder, we have people falling off of mountains, and crush injuries can be a cause. The specific mechanism is a rapid deceleration or a direct blow to the precordium. If we think about the thorax, there can be compression of the heart between the sternum and the spine, and that can cause injury. We can have shearing injuries and also blast injuries depending on the mechanism of a specific trauma. We'll talk a little bit about the anatomy, but the right heart is injured most frequently because of its position anteriorly. High pressure injuries to the ventricles are most common on autopsy studies. The issue there is that most of these large ventricular injuries just don't survive to the ER to have definitive care. But atrial injuries can occur. And we'll talk more about valvular tear or rupture, as well as septal tear, and then the coronary artery abnormalities. So one algorithm to kind of think about in trauma patients who are at high risk for cardiac injury, if the patient is unstable, then we proceed just down the road of resuscitation and surgery. And so, the trauma surgeons in the room are the experts at this. But if they're more stable, then I think a reasonable pathway is to consider further imaging. So if there's evidence of penetrating injury, then proceeding with a fast scan, looking for pericardial fluid. And if there is, then proceeding with surgery. If there's not, considering proceeding with a CT scan. And then we get down the blunt cardiac injury CT scan pathway, where if we see cardiac injury, if the diagnosis is confident based on our radiologists and the CT scan, then we proceed directly to treating the specific cardiac injury. If it's equivocal, then considering proceeding with emergent echocardiogram for further information. And then if there's no evidence of cardiac injury on the CT scan, if there's a low suspicion, then we're done with the algorithm. And if there's a very high suspicion based on clinical characteristics, then proceeding with an echocardiogram. I put this in here. This is going to be hard to read, but there is a American Association for basically the Trauma Surgery Society does have an injury scale that can be used by emergency room physicians and trauma surgeons, ranging from grade 1 to grade 5 and going up in severity. I just kind of bring that out so that we can think about the idea of kind of grading the severity of our patients with regards to cardiac injury. I think a key thing with regards to trauma is understanding the relationships of the structures in the chest and mediastinum. Obviously, for penetrating trauma, if we're within 1/3 of the right side of the sternum and 2/3 of the left side of the sternum, we could be at risk for direct heart injury. But we have multiple other structures, vascular structures, including the major arteries and veins, and then obviously the lungs and other structures of the chest. So I think it's key to kind of think about that when we're looking at the idea of especially penetrating trauma, but also if there's evidence of blunt trauma, and specifically we see evidence that a certain part of the precordium has been injured, then we may want to consider injury to specific parts of the heart itself. So I think we're all in agreement that there's 4 chambers to the heart in most patients. So I kind of put in a little bit of anatomy, and I'm not going to go into full detail, but I think the key points to realize with regards to anatomy, the top frame is kind of looking more anteriorly. So we see the right-sided structures more anteriorly. So the right atrium and the right ventricle, and then the pulmonic valve there. And then as we look at the bottom frame, then we see, we still see some portion of the right ventricle more posteriorly, but then the left ventricle is again more posteriorly, as well as the aorta. And the importance here is that kind of the frequency of traumatic injury increases as things are more anteriorly because of just the the sternum and the rib cage is thinner than posteriorly, and so as we're kind of looking at specific cardiac trauma, we should consider the anatomy specifically. So myocardial rupture is a life-threatening event. So most patients with uncontained rupture don't survive to the emergency room. If it's a smaller rupture and they make it to the emergency room in time for axial imaging, we can see hemopericardium on the CT scan. We may be able to see actual loss of continuity of the heart muscle, such that we see the portion of heart muscle which has ruptured. The other issue is that some patients can develop necrosis of the myocardium from trauma. And so if a patient, into their hospital stay acutely decompensates, one thing to consider would be that we could have delayed rupture. And that's kind of similar to what we see historically when we had myocardial infarctions that were treated conservatively as opposed to with early revascularization, where heart muscle over time becomes weakened, and then because of the pressure of the chambers, especially the ventricle, can rupture because of that. Generally speaking, atrial rupture, because the atria are generally more compliant, is only about 10% of all ruptures. And all of these may present with tamponade, so we'll talk a little bit about tamponade here. So the heart obviously sits in the pericardium, and normally it requires some amount of fluid to allow the heart to easily move within that sac. The issue is that the sac is a contained space, and fluid is incompressible. So when fluid rapidly accumulates into the pericardial space, then the only thing that can give is the heart. And so what happens is that the increased pressure in the pericardial space then compresses the heart. So on physical exam, the things to look out for are things like muffled heart sounds with significant hypotension and significant distended jugular veins. Patients may be very short of breath. They may feel better sitting upright. And so specifically what we look for on echocardiogram in this representative picture is the idea that the right-sided chambers, the right ventricle and the right atrium, are being significantly compressed. If we were to leave this alone, then the patient would be unlikely to survive. So rapidly removing that fluid, either in a surgical manner in the ER or in the OR, or from a less invasive approach, placing a pericardial drain, is key in helping save these patients with acute tamponade. Moving on a little bit to septal and valvular injury. Fortunately, the septum is between the chambers in the heart, so injury to this is rare. In literature, we do see reports of acute septal injury, and so we can see that clearly on echocardiogram, where we see profound color flow between the ventricles in the middle diagram here, and we see a discontinuity in the septum on the leftmost picture. And then there's a CT scan which correlates with these findings in this patient. And then here specifically is the surgical picture of this injury that was repaired. These can be insignificant, a small little tear that doesn't make any clinical difference to the patient, but frank rupture can be life-threatening for patients. They can occur in isolation or also with valvular injury. And I think the key thing to look for in these types of injuries is signs of acute heart failure. So acute hypoxemia, acute shortness of breath, orthopnea, P&D, swelling in the legs, These types of findings may suggest that looking at an echocardiogram, or I should say also a new murmur, especially a murmur throughout the cardiac cycle, would be suggestive of a septal injury. And finding this early and then talking to surgeons to fix it. Depending on the tear, sometimes these can be fixed percutaneously if it's deemed that the patient would not survive surgical repair. So we do have septal occluders that can be placed in the cath lab as well. So that would be an option for some patients. And so specifically about the signs and symptoms of acute heart failure. So low blood pressure, cold, clammy skin, shortness of breath, orthopnea, meaning that the patient feels much worse when they lay flat and better when they're sitting up, low oxygen saturations, crackles on exam, and then elevation of the jugular veins. And specifically, we're talking about left-sided heart failure here. Again, valvular injury is not a common traumatic injury to the heart, and specifically isolated valve injury is rare. Most commonly, this is the aortic valve, and then followed by the mitral and then tricuspid valve. They can be a tear of the leaflet, partial or full thickness tear of the papillary muscle, which helps keep the mitral and tricuspid leaflets from flailing back into the atria. And so it depends on which side or which valve specifically is injured as to what signs or symptoms we should watch out for. So if it's a left-sided valve, we would worry about left-sided heart failure symptoms. If it's a right-sided valve, more right-sided symptoms. But the things that we may see as signs, specifically with aortic valve pathology, is a very wide pulse pressure. So, if the systolic blood pressure is 150 and the diastolic is 30, we need to think about whether there may be some valvular insufficiency at the aortic position. So, again, not to teach everyone reviewing echocardiograms, but we see profound turbulence in the aortic position, which is all this yellow to orange color in this aortic valve, which has been ruptured acutely in a traumatic patient. And so these, again, the heart does not tolerate acute aortic regurgitation well. It does very well with chronic aortic regurgitation, and it takes a long time for people to require repair. But if these types of things occur acutely, people decompensate very quickly, and if we can't fix that urgently or emergently, then patients are unlikely to survive for very long. And I want to show a case that we saw recently here. So this patient is one of our patients locally who was in a motor vehicle collision and was treated at another hospital, and then started having worsening of a murmur and worsening symptoms. And so what we see kind of flapping is a portion of the subchordal structure of the mitral valve. So on the right side, you see that structure that's flapping into the atria. The atria is the top part of this picture. The left ventricle is the bottom part of this picture. And we see this kind of very eccentric color flow wrapping around the left atrium. And so this, and then in 3 dimensions, kind of the bottom part, we're looking at this, the surgeon's view is kind of a fish mouth view of the mitral valve. And at the bottom part, we see that structure that's discontinuous, kind of flapping up into the atrium. So this, classically, this looks like bad mitral valve prolapse disease, but this is a more acute process that the patient developed because of a motor vehicle collision. So kind of keeping an eye out for new murmurs in patients who have had trauma can be important, because they can have changes to their valves that require surgical intervention. He did end up going on to have surgical intervention and has done great with that. Finally, I just want to talk a little bit about myocardial infarction caused by trauma. So we can see specifically occlusion of vessels related to, compressing coronary arteries. So the artery could be lacerated, it could be dissected or torn, or we can have a thrombus formation in the artery itself caused by trauma. And depending on the mechanism, either taking the patient for bypass or bringing them to the heart catheterization lab like I showed earlier and trying to open it up and put a stent in may be beneficial. And then because of the anterior position of the left anterior descending artery, based on the name, you would expect that. That's going to be the most commonly injured vessel in trauma. But obviously, we want to keep an eye out for that if patients are having symptoms, ongoing symptoms that are out of proportion to what we would expect based on the trauma. Again, an ECG is an easy test to screen for these types of things, and then we can offer life-saving therapies and also reduce morbidity if we identify this early. There's this other idea of kind of cardiac contusion and cardiac dysfunction. The challenge with this in trauma is that there's really no clear definition. So, part of the issue is that if we track sensitive biomarkers like troponins in patients after traumatic injury, sometimes those are abnormal, and that may or may not be clinically meaningful. If they clearly have signs of heart dysfunction, then a screening echocardiogram is important to try to make sure we're not missing some more major injury to the heart. And then there's also this idea of stress cardiomyopathy. So we see patients sometimes who present with signs and symptoms which would be suggestive of an acute heart attack. And so they can have ST elevation on their ECG. When we look at their echocardiogram, they have wall motion abnormalities, most commonly in what would appear to be an LAD territory, so in the mid to apical anterior wall, and can also wrap around the apex. And elevated troponin, they have chest pain, shortness of breath. And so, most commonly this is thought to be caused by a profound sympathetic outflow. So emotional stress, but also physical stress can be a cause of this syndrome. And some patients can be so sick that they require advanced support, even mechanical support to their heart to recover from this process. The vast majority, though, recover with full recovery of their heart function and do well. So some risk factors to think about. This is more prevalent in women versus men, postmenopausal women specifically, patients with schizophrenia, anxiety, depression, asthma, diabetes, and then substance abuse disorders. We see this more frequently. So something to consider, especially if a patient is decompensating and we don't have a clear reason. At least screening with an echocardiogram may be reasonable. And just finally, some heart rhythm abnormalities that we see in cardiac trauma. So most commonly, we see sinus tachycardia. This is the heart's response to stress, and specifically if we're worried about things like hemorrhage causing hypovolemia, that would be a primary consideration in trauma patients. Now, that being said, if this persists for long periods of time after adequate resuscitation, or if there are other issues such as new bundle branch block or minor heart rhythm abnormalities like PVCs, we might want to be concerned that there may be blunt cardiac injury. And so at the very least, I would recommend admitting the patients for monitoring on telemetry. But few patients will require specific treatments. It's mostly just supportive care. But getting a formal ECG, considering looking at troponins just to make sure we don't see evidence of specific injury, and then an echocardiogram is a very safe test to look for major abnormalities. So in conclusion, cardiac disease can be a cause of trauma. So if we don't think about it, we may miss that, so I just kind of bring that up. It can vary, so once traumatic injury to the heart occurs, it can vary from very mild to life-threatening. And consider blunt cardiac injury, especially in our patients who have persistent symptoms despite aggressive resuscitation from their other injuries. And for patients with symptoms of heart failure, acute valvular abnormalities, significant arrhythmias, cardiology consultation and/or echocardiogram may help identify other therapies which could be life-saving. And so with that, I'll take any questions. Yes. You know, that's a good question. I mean, I looked briefly at some of the notes from the other hospital. I didn't see a record of anyone noting, you know, a heart murmur. I think clearly listening to the heart and making sure we don't hear something that's abnormal. The challenge with that specific injury, again, like I talked about, there can be delayed rupture. And so it's possible that, maybe it wasn't present in the emergency room when they did their workup at that time. So I think the key thing is kind of keeping an eye out for changes, or especially if the physical exam changes. So, if someone doesn't have a murmur and suddenly they do, I think it's important to think about that. What is the reason? And but yeah, it's hard to say. Yes. Yeah, and again, I'm not a cardiac surgeon, so but we try to repair valves as best we can. The issue is that the native valves last, for many people, they last a lifetime without any issues. And when we put prosthetic valves in, generally they have a lifespan which is not a human lifespan. And so if we can repair valves, we prefer to do that. So we have a lot of experience, in the mitral space that if we repair the valves as opposed to replacing it, that's a better option. Now, the challenge is that it depends on the mechanism of the injury and whether the surgeon thinks that they can repair it or whether it needs to be replaced. And so that's an important decision that surgeons make. And, they try their best to repair things. Sometimes things aren't repairable. And either, the reality is that the patient would probably not survive if they didn't have some intervention. And so we need to do whatever intervention we think is right. And so kind of move forward that way.
Thank you, Dr. Shapiro.
Thank you.